How do I test for thyroid is the question. Well, I typically like to use the basal temperature. There's lots of research, and my homeopathic doctor group lets me do that. I can tell you the temperature doesn't move much. Dr. Tennant got really exasperated with it because it just kind of goes up and down for a long time until you get up to a therapeutic dosage, and then it tends to elevate and level off. Dr. Tennant has developed treatment, but he likes to use the free T3, and he has basically a whole new protocol, which I'm sure is 10,000 times better than the current standard of care. But the best thyroid doctors and hormone doctors I've learned firsthand, and Dr. Schallenberg is one, that you do the blood test to cover your rear end with the medical boards, and then you treat the patients. So, and like I said, I think you can almost go by the weight these days. I've treated so many people, and there's so much. But so to answer your question, so I use I do the free T3 and the free T4.
Do you do reverse T3?
Reverse T3 is what Dr. Tennant recommends as well. So Dr. Tennant has a chapter in my latest print of the Type 2 book. So he explains his research in his own thyroid. He's got a big chapter on low thyroid, so he's more of the lab guy. But I can tell you, I just set a new record on how much thyroid a woman needed. She had a thyroidectomy. So no thyroid. She was almost 300 pounds. She was relatively young. She was still menstruating, so she had healthy arteries. And she required 10 grains of thyroid before she felt well, started exercising and losing weight. So that's my all-time record, is 10 grains a day. I'm going to say. So Rhoda Barnes, when he lectured, he changed from a low fat to a high protein, just for food, what I want to say. Anyway, like I said, I'm still a little scattered for this diet. So he had a high protein diet. His need for thyroid went from 4 grains to 8 grains. He thought he had a bad batch of thyroid until he switched back to a diet high in fat, and he only needed 4 grains again. So there's all sorts of different reasons why you might need more or less. And you can't really treat the blood tests, in my opinion. But there's been so many people who've been treating the thyroid, just like my old teacher. You know, you give them enough, this is what they used to do, until they feel well, or else they have side effects, and then you start looking for mold. I can tell you, people that have a mouthful of metal and root canals, no problem giving them thyroid. Of course, it doesn't, most of them won't get well until you take their teeth fixed. But boy, that mold stuff is really a booger, and you have to get treated for that because they're allergic to everything, including themselves. So do the blood tests, treat the patients, and if you get problems, don't keep cranking up the thyroid and figure out why they aren't tolerating the dosages they need. And I have a lot of that stuff in my books about what type of thyroid I use and why, and I also have the what I recommend for blood tests and so on.
Yeah, I'd like to weigh in on this. This is one of my passions, is thyroid. I would love to hear some of the stuff you were bringing up today. Thyroid, as Dr. Starr points out, regulates metabolism. It regulates mitochondrial function. What do mitochondria do? They use up oxygen. So what you can do is you can measure what we call VO2s. Are people familiar with VO2s? It's how much oxygen is disappearing into your body. So you can measure VO2. It's simple. You get a mask, you put a mask on, it's kind of like a scuba mask, and as you breathe through it, it's connected to an analyzer. It'll measure how much oxygen is disappearing into your body. That actually quantifies your mitochondrial function. So you can do lots of interesting things. You can check somebody's VO2, and then you can do something and check their VO2 a half hour later and see what that thing did. What do you suppose happens if you give them thyroid and then check their VO2 again? It can dramatically go up. What if it doesn't? What if it doesn't? That means they need more thyroid. So you give them more thyroid, check their VO2. Doesn't go up that much. And you keep doing it until their VO2s become normal, because we know what's normal. Luss figured that out in 1932. So we know what VO2s would be normal for a normal, healthy metabolism. I've been doing that for about 15 years. What I can unequivocally tell you is that for diagnostic purposes, all thyroid blood tests, completely useless. Forget them. They're absolute. RT3, T3, free T3, total T3, the whole shebang, for diagnostic purposes, completely useless. You will never have a clue who needs what, much less how much they need, if you're looking at thyroid tests. If you look at VO2s, different world. Now we've got something that we can count on. So what you do is you check your VO2. If you don't have the ability to check VO2s, it's about, $12,000 worth of equipment. It's pretty easy to do. But if you don't have that, the next best thing is to take a coin and flip it. Use your clinical skills, use your clinical judgment, start with like a 1 grain or a half grain or whatever you think is right, and just every 2 weeks keep increasing it until they get a tachycardia and back off. Seriously. But if you want to do it scientifically, you measure their VO2s, and I highly encourage every one of you, if you're interested in thyroid, listen, of course you're interested in thyroid. You want to make people well, and you won't be able to if you don't fix their thyroid. They will not get well if you don't fix their thyroid. This is a rate-limiting phenomenon. We're talking about mitochondria. So I hope you will look into the VO2 thing and start measuring the metabolisms of your patients. Marvelous things happen when you start doing that. But the cool thing is, you start them on the thyroid. Now, after you can get their baseline hormones, okay? If you want to get baseline hormones, I'm good with that. You get your T3, your T4. They're okay to monitor and follow what you're doing, no doubt, okay? But I will tell you this unequivocally. If you're over 50 years old, the odds are pretty good that you're going to need enough thyroid to suppress out your TSH in order to get your metabolism normal. That TSH is a completely bogus test, and that's in the literature, right? The literature states that with people on thyroid, TSH is a bogus test. Forget it. If your medical board thinks that TSH is the test of all tests, you can show them some VO2s, and that's well established in the science since 1932. So what you do is you check their VO2s. If they're low, you give them some thyroid, recheck their VO2s. If it's not high enough, give them some more thyroid, and you get your doses dialed right in. And one other point I want to make, when you get the correct dose of thyroid, very often, 3 to 4 months later, you have to lower it. Why? Because thyroid stimulates the mitochondria of every cell in your body, including your thyroid cells. So that's something that you want to look for. So I always tell my patients, like your 10-grainer over there, watch him. Because in about 3 or 4 months, she's going to start getting tachycardic. And at least you might, anyhow, and you might have to reduce the dose.
One more comment about thyroid. The thyroid is innervated by the autonomic nervous system. And perhaps some of you have noticed occasionally you'll have a patient with whiplash who will develop hypothyroidism. These ones look at the autonomic innervation, look for stellate ganglion problems, the thyroid itself. Amongst the German neurotherapists, they pay a lot of attention to what's called the thyroid, the tonsillar thyroid pelvic axis. Now, tonsils is shorthand for superior cervical ganglion. So they will very often inject all 3 of those areas in an attempt to regulate not only the thyroid but pelvic function and upper problems as well.
Can preconditioning help us with supporting our thyroid?
What's the question again?
Can preconditioning with the ozone help us with, or what are some things we can do to support that?
So obviously ozone is going to stimulate metabolism, but it doesn't stimulate it through the thyroid. I mean, you can stimulate metabolism by eating food. So when you're checking VO2s for thyroid, you specifically say no exercise, before, within, say, 12 hours, no food, no coffee, just, it has to be in a basal state in the morning with lots of rest, and then you check, because everything stimulates, including ozone, will stimulate metabolism.
On the scarring question, when you treated yourself with the iodine, the final picture in 2014, was that the final photograph, or was there a point where you applied the iodine and there was no staining, or there wasn't the look that you had in the photograph?
Was there a point where what?
When you showed the photograph, you had the iodine, it wrapped all the way around your foot, and it didn't look so pretty.
Yeah,
So,
both feet.
Was it? Was there a resolution of that complete staining around there? Or is it...
Oh, yes. No, the scars are all gone now. Voltage is flowing to my brain again, thank goodness. And I'm going to write an ebook on scars, thanks to all my first-hand experience. And I have more pictures than just the ones I showed. So I'll be writing an ebook on scars because people need to know about that. I've got about 3 or 4 more ebooks I want to write. Thanks. Go ahead.
Can you speak to, or maybe I missed it, what about administering iodine at the same time that you're treating with grains of thyroid? For example, I have a goiter in the whole
Everybody needs iodine. David Brownstein has a book, Iodine, Why You Need It, Why You Can't Live Without It.
I've read it.
Just thyroid hormones are made from iodine. And if you aren't taking any iodine, you're getting bromine and fluoride and chlorine and all the stuff that are in the halides. And Dr. Tennant has research showing you can make fake T3 and T4. You can actually convert fake T4 into fake T3, so that's another reason why the blood tests don't work. And the amount of fluoride that's in our water in the United States is enough to slowly destroy your thyroid gland.
So how do you find out which iodine is right for you? I'm assuming you're a
it
proponent
depends.
of blue balls.
The patients with severe allergies, I tend to use 1 drop topically, and oftentimes I won't even do that if they have severe allergies and mold and Hashimoto's and so on and so forth. I've got to detoxify them a little bit. Sea salt, a really good sea salt like Himalayan or real salt is what I recommend. Helps the body detoxify and is the antidote for iodine reactions. So I oftentimes will start with the sea salt, start to crank it up to like a teaspoon a day on food and in water. The hypertensives may not tolerate that. But then I start with like 1 drop topically on the super sensitive patients and increase 1 drop of 2% Lugol's iodine topically very slowly. And after a while, after they're on 4 or 5 drops of topical, because it's not absorbed very well, even though it disappears from the skin, so then you can start doing internal iodine and slowly increase that. So everybody needs iodine. The average adult dose, Jonathan Wright thinks 12.5 milligrams is enough. Dr. Tennant and I think it's more like 18 to 25 is the adult dose. Dr. Brownstein thinks it's higher. So anyway, there's different, but all 12.5 for adults. Of course, little kids need a lot less. So 1 drop every 3rd day or every 5th day. You have to, be careful in pregnancy. I've treated enough pregnant women. I don't give more than 6 milligrams if they become pregnant, because too much iodine can cause problems as well with the fetus. Is that good enough? Okay.
Yeah, my question was pretty much the same. The clarification of how much topically and where, and then how much orally, and how do you take that?
I have guys muscle tested for years and years and years and years. So I have with the younger folks, I have milligrams per kilogram in my type 2 book, the bigger book, that I think is accurate. I've treated lots and lots of small people, and you have to be really careful. I told one guy to give his son 1 drop a day topically. He was squirting a whole dropper full down the poor child's mouth daily. I told him to call poison control. And he did, and they told him that it was 2% Lugol's. Had it been 5%, he would have needed to be rushed to the hospital, but just stop. But of course, he never came back after that. I felt badly, but gosh, you know, one drop topical doesn't mean a whole dropper full every day for a 4-year-old or 6 or whatever the child was.
You know, I can tell you a couple of things that I think are interesting. One is I had a bottle of 2-grain thyroids. I think there were about 200 of them in there, and my dog ate them. Okay, and he was just fine. So there you go. And also, iodine's really great for chronic prostatitis. Chronic prostatitis often mimics prostate cancer, and you can't hardly tell the difference sometimes. So for a lot of rising PSAs, I will give in the order of 50 milligrams of iodine twice a day for 9-12 months. I've never ever seen a problem. I don't want to say that you can't get a problem. I don't know if anybody's seen a problem with doses like that, but I commonly will use that, and so that's 100 milligrams a day for 9 months. I don't see a problem with it. Haven't yet.
Really, just if there's Hashimoto's, you're going to run into problems.
Not necessarily. I've given it to people with Hashimoto. A lot of these people have Hashimoto's, you know, by laboratory, but not by clinical. Laboratory form of Hashimoto's. I just haven't seen it. I know that's supposed to happen, but just haven't seen it.
Can anybody comment on HRV testing, the autonomics, sympathetic and parasympathetic?
Heart rate variability. For what, though?
Just to check the autonomics.
It's great. I mean, it's been done for decades. Heart rate variability for the autonomics is excellent if you got the right program.
Okay.
But is there a comment?
Yeah, I have a heart rate variability machine, but I really don't use it. I've used it occasionally for medical legal reasons. Now, there is a people who do use them regularly can really accumulate information from them, but you have to use them enough. There's a chiropractor in New York State, I think, I've forgotten his name, but he's made a study of this. He's done heart rate variability on every patient for years. And he can draw out a lot of information that other people don't have. It's like a lot of tools. You have to use them a lot before you can really be secure about what you're seeing.
So going back to the thyroid and the iodine issue, for Hashimoto's, I take 3 grain of the nature thyroid, and I take 55 milligrams of iodoral every day. You said 9 months. Is it an issue? Because I feel better when I'm on that high of a dose.
I don't know if you guys heard that. She takes 3 grains of nature thyroid and 50 milligrams of iodoral. And the question was, is there a problem with that? Is that the question? Of course, I would check your VO2s and see, and that would be the answer. You might need 4 grains. If you've been doing 3 grains for a while, you might need 2 grains. I mean, it's hard to say without, doing that. But if you don't have VO2s and you can't look at that kind of thing, that's okay with me. If you feel good and you're not tachycardic, you don't have symptoms of elevated thyroid.
Do you feel well? Well, good. Then keep doing it. That's the bottom line, right? That's how medicine was practiced until we were instructed to treat the blood tests instead of the patients. So if the patient feels well, that meant you were right giving it to the patient. Unfortunately, that's not true for 45 years now, but at least it's not practiced. So you have to treat the patients, and if they improve, just like the B12, if they feel a lot better on the B12, they need it, and keep giving it to them.
Yes, for Dr. Warwick. Just
interested when you did your studies with particulate, was there much variance on the outcomes based on the volume and the size of the fillings being removed? I know in my practice, of course, there's people that have one or two small fillings and others that have quadrants that need to come out. Just wondering your thoughts on using those protocols on that variety of situations.
Well, first of all, there is a huge variation from site to site. It's kind of a random thing, and depending on location of the filling, there can be a different spread or footprint that that particulate lands on. When we did the little 2x2 or 5x5 centimeter that were sewed onto our smocks, that was done. We took out about 1,000 milligrams of mercury. We just used some 3D X-ray or 3D technology to figure out the volume. The Joes and Matts, when they did their 10x10, they were taking out about 750 milligrams of mercury. So it didn't really, it's more of a variable thing. It's unpredictable, and that's the problem. And the other thing that I think that we kind of missed today was that the mass of the particulate did not correlate to how much mercury vapor was coming off that particulate. There's some, I know we had one that was a 26 microgram, I think, mass, and it had one of the highest volatilization rates. We figure that this would be because of both it could be the burr, a little duller burr, maybe a little less water, the different types, the copper, high copper amalgams. So that variability rate is important, but the point is it's a solid material that contains mercury, and there's no safe level, and all skin has to be protected from that.
A real quick question about when you're using glutathione and ozone in the same day for Dr. Shea and Dr. Schomburger. What, before or after, which goes first, and the benefits of doing it that way? If you were going to do a glutathione push before MAH or another form of ozone treatment.
Ozone, if you do ozone and glutathione the same day, what order would you do?
Which comes first?
Yeah, this is a really interesting thing. In the world of ozone, you're not supposed to mix these two. Even maybe 2 years ago, the dictum would be on the day that you give MAH or give any ozone therapy, really, you withhold all potentially antioxidant nutrients. That's the dictum. You know what's happened since then? It's the exact opposite. Now you give them together. So that's pretty interesting, isn't it? I can tell you that I started using glutathione based upon some of my colleagues telling me that it worked pretty good clinically. I couldn't figure out what the heck's going on, but here's the deal. It works great. They're really great together. Also, ozone and vitamin C works great. You do the ozone first. So what you're doing now is you've got bloodstream loaded with lipoperoxides. And after that, then you load the bloodstream with glutathione. Now, I don't know what's going to happen. Maybe you know what's going to happen in there. Maybe the peroxides oxidize the glutathione. Maybe nothing happens. I don't really know. Maybe our patients, by definition, are all depleted in glutathione. That's probably true. They might be depleted in vitamin C. Maybe Dr. Shea could speak to that. But I can tell you that clinically, it works great. Here's what I routinely do. I'll give 150 cc's of MAH and follow that with a gram of glutathione IV. It's a lot of glutathione. It works great. One little pearl I'll tell you. Don't use a bottle of multi-dose glutathione. You will have reactions. Get single ampules, 1,000 milligram single ampules of glutathione, and use that. And you'll never get a reaction. But if you use the multi-dose vials, there's something that happens over time with those things, and you will start getting reactions to glutathione. But I think they work great together from a clinical perspective.
I first talked about that at the ozone show at your conference, and I brought it up a little bit today. Damaged forms of glutathione are a hormetic trigger to upregulate damage control genes. And so just like taking lipoic acid hits this NRF2 trigger, damaged glutathione does it. And the worse the damage, the harder it hits the trigger. So it's a weird way of getting there, and that's why it's so counterintuitive, but that's very likely the mechanism that's making it work. And I'm assuming then that, so when you crank up that oxidized amount of glutathione, it does it. And perhaps with the C, it does that too. Because you're trying to keep all those in a highly reduced state. And when the oxidized forms come up, it's a trigger for you to turn up your reductases, and they come along with a bunch of other genes that are reparative.
Oh, that's cool. That's cool. Thank you for that.
You're welcome.
I'm sure everybody got that. How do you want to make that?
Did you guys get that? I mean, that's huge. If I learned nothing else this weekend and I got that, I'm a happy guy.
We'll do it again.
Okay, so he's back. If you didn't get it, correct me if I'm wrong.
Yeah.
But you're got the peroxides in there. Now you're going to infuse the glutathione, and you got a high level of peroxides in the blood. That is going to damage the glutathione. And the body recognizes that. It sees, oh my goodness, we got damaged glutathione. We have to react to that. And it's that reaction that is a healing mechanism. Pretty cool. I like it.
This is, it might be sort of random, but, and I can't remember your name in yellow, I'm sorry. Yes, Dave. I'm sorry. But when I take a lot of root canal teeth out, and of course, if any of us have sectioned through a root canal, smell mold. And as far as protecting ourselves, you know, we talk a lot about protecting ourselves when we're sectioning mercury, removing mercury, and all that stuff. But when I smell that stuff, are we actually, is there a chance that we're breathing in mold toxin or spores, or the spores getting on our skin? Like, because we know what's in there, we smell it. And if there have been any studies on that, or if are there any protocols for that, and or if I'm just being weird, but I smell it and it bothers me.
Yeah, you're not being weird. Chris Shade's being weird. If you asked Dr. Tennant what he thinks about the volatilization of various bugs in any surgical situation, he'll tell you for sure it happens. Using the face masks is, I think, imperative when you're removing root canal teeth. As I would be using a better mask than, say, your typical ear loop mask. Something like 3M makes a very small particle allowance. It's a 0.3 micron aerodynamic, and that would be helpful, I'm sure. But that's a good thing to study. I don't know of any study that's said that. So.
Smell is chemistry. So if you smell it, you're inhaling it, you're absorbing it. It's all yours.
I have a question for Dr. Shade. On the Quicksilver products, I keep hearing different things. Like, I know the directions for your products, they take the glutathione like 5 minutes, and then 5 minutes later take the vitamin C and make sure you don't eat anything, and it's very confusing to patients. And then I've heard it doesn't matter if you take the glutathione pump and the vitamin C together. So that's my first question.
Yeah, the only thing you want to keep the glutathione away from is the IMD, because they're both sulfhydryls and they can cross-link and sort of neutralize each other. But the C and the glutathione go together great as long as you don't have the IMD in there. Pretty much all the liposomes can be mixed. And yeah, that's the only real rule there.
And how critical is it that they're refrigerated? Once you open it, does it need to be refrigerated right
Well, it depends how good you want it to be when you take it. So it's not like the day you take them out of the refrigerator and get on the plane and come to the conference to have your glutathione that the thing dies. It's all just a relativity game. How many days does it last like that? So in the freezer, if you keep it in the freezer and take it out, use it, put it back, that's just stopping time. Yeah, I mean, that bottle will be good for 3 years. If you leave it in the fridge, you only say 30 days, because as you're consuming it, you have more oxygen going in there. And this is really, it's for the C and the glutathione. And then if it's at room temperature and you're using it you got, 2-3 weeks till it's starting to, you'll notice it starts to get off flavors. And if it's C, it starts to darken a little bit, and that means that you're oxidizing it. But the colder you keep it, the better. In fact, when you get it into your office, if you have a little freezer in there, keep stuff in the freezer. It just stops time.
If the bottle's unopened, is it only good for 30 days in the refrigerator? If it's unopened?
If it's unopened,
Yeah.
it's only good for 30 days in the freezer. What?
In the
No,
refrigerator.
it's good. Just keep it in the. If you keep things cold, they stay perfect for a long time. But they're good in the fridge for a year from manufacture for the glutathione, and pretty much 2 years to 3 years for everything else.
And can you just quickly go over what you would recommend if patients can't afford your Quicksilver Mercury Detox box and they only are getting glutathione, vitamin C, and the IMD?
Right.
What dosage would you recommend of each after mercury removal?
Well, you want to start them where they can tolerate and move them up from there. And so start with a scoop of IMD a day, and of the liposomes, start with 2 or 3 twice a day, and see if you can titrate them up over a couple of months to 2 times that and then 3 times that. And if you can get up there and stay for a couple of weeks, you can get a lot done in 3-4 months like that. And then if you want to keep them on a maintenance after that, 1 scoop a day, 5 days a week for a few more months, and 1 or 2 pumps of each liposome twice a day, that really sets it in. And then if you want to break it all the way down to just 2 products, you got to figure out if they're tolerant of lipoic acid. You could do IMD and lipoic acid for younger people, and IMD and glutathione for older people, just because their glutathione levels go down so much. They benefit from the glutathione. But any way you put these protocols together, the key is to start low as they tolerate and work up higher. And if you get stuck where you cannot titrate up, there is something in there that must be killed. There is an infection, no doubt. And don't buy that, get the metals out and the infection goes away. You're never going to get the metals out.
Dr. Kidd, you gave an example of treating trigeminal neuralgia. Have you treated many of those, and do you have success with it?
Yes. I've treated a lot of them and generally been successful. It's mostly a dental problem, though. So it's one where I need the cooperation of a dentist. Neural therapy turns down the autonomic nervous system, but it's not going to stay down if it's very toxic or if there's infection occurring there. I use cranial osteopathy as well. In fact, I probably use cranial osteopathy as much as neural therapy. They're both ways of addressing autonomic nervous system imbalance. And it's really helpful to be able to do both. Tic douloureux, that's a more difficult one, but I have been able to treat those ones as well.
My question was, there's in the pro-oxidant approach to killing infections, some people have used MMS, or the chlorine dioxide approach, which sounds like a really heavy-duty pro-oxidant approach, and apparently it's been used with some success in the autistic children in the belief that they have major infectious issues that need to be taken care of first, and then probably following up some benefits in the detox side. But just wondering if anyone has any comments on the chlorine dioxide pro-oxidant approach. And I think they do, the protocol does say stay off of the antioxidants, stay off of the vitamin C and other antioxidants. So,
just curious as to whether you have any quick reactions to it. Anybody?
I'm one of those guys that does not believe in the germ theory. I do not believe that infections have anything to do with the deficiency of antibiotics, ever. I'm including endotoxic shock in there. I don't think this has anything to do with the infectious agent. I think this has 100% to do with your system. As Beauchamp would have said, the milieu, but it's the way your body's set up. You could throw your immune system in that. You could throw your interstitial space. You could throw your VO2s. You could throw your metabolism. You could put your heavy metals in there, whatever you want. But that's why people get infections and die from them. And we all get infections. You're supposed to get infections. That's how it upregulates your immune system. It's basically the nature of these vaccinations we all love so much. They give you a kind of a concept of an infection, so it's actually good for you. It upregulates your immune system. But what's not good for you is dying from it or ending up in the hospital or and all that. What's not good for you is having to take antibiotics for it. So with that in mind, why do we cure? Why do we take infections of so-called infectious diseases like Lyme disease, for example, Borrelia, and the co-infections? Why do we get the so-called infectious hepatitis? Why do we get the so-called AIDS? That perked your ears up, didn't it? Okay. Why do we get the so-called HIV infections and cure them with oxidative therapy and no antibiotics? The answer is we're not killing bugs. We're absolutely not killing bugs. You don't get anywhere with killing bugs. I can't tell you how often I have patients come in diagnosed with Lyme disease and co-infections that have been on, I'm sure you've seen these folks, the worst case of antibiotics that you could ever imagine for 2 years. And are they better? No. They're actually worse because now they have systemic fungal disease. They're not better. Well, I'm here to tell you, if you have a quote infectious disease and you take a ton of antibiotics and you don't get better, maybe you don't have an infectious disease. Maybe that's why. So anyhow, yes, it changes the milieu. These oxidative therapies change the milieu, and they work great with antioxidants. And I think that the MMS is a good example. It's changing the milieu.
So you see.
So I don't look at it as an antimicrobial effect.
So you see some merit in it, but not for the mechanism
I've heard great things about that stuff. I will say that we sent a guy over, I'm talking about our academy, sent a guy over to Africa to treat malaria with MMS, sent him over with a big old shipment full of MMS, and he did pretty well with it, going out to these rural villages where they don't even have running water with a case full of MMS and really helping people and fixing them up.
Yeah, but I like other pro-oxidants a lot better. MMS is cheap, and he has his bathtub gin of pro-oxidants, and there's probably far more autistic kids who had a train wreck with it than had success. And being the way I am, I tried it out in a large amount, and it was not.
So that's what happened to you.
No. That
explains a lot.
But that was only recent. How do you explain everything before that?
So I was at Dr. Tennett's seminar recently, and he said that the MMS is more hype than what it really does. And so take that, it's what it's worth.
I first of all wanted to say there's some incredible brain power sitting up there, and thank you for sharing your knowledge. It's really impressive, honestly, so thanks. My next question is, with the ozone therapy, is there a threshold? You were talking about peroxides, and is there a threshold for peroxides in the body?
Yes, of course there is. So you're saying, is there a time when you can have too many peroxides, right?
Yes.
Yeah, it's a seesaw. It's a balance mechanisms. So yes, you have oxidant stress, and you have systems that control that stress. If the oxidant stress exceeds the systems, we've got a problem. And so it's similarly, by the way, if the systems, and the systems actually won't do this, but if you were to take too much of an antioxidant, say you take too much vitamin C, too much beta carotene, you know, like fairly stiff doses when there's actually nothing wrong with you, and you overload it that way, that can be problematic as well. So you do want to get the balance. Dr. Shea basically gave you some pretty good advice, and that is sort of start off low and just taper up. If you go up slowly and you just follow the general instructions, the Germans have been doing this for 60 years, so we have some really good clinical data on what works and what doesn't work and what's too much and what's not too much. If you just follow their guidelines and start off low. And I was telling people at the break, if I decide that the patient needs, you know, this much ozone, the first time I give it to them, I give them this much. And if they handle that all right, I give them like half the dose that I want to end up with. And then I go to 3/4. If I don't see any problems, I'll give them the full dose, and then we'll just go with that. But it gives me a chance to step up, and then they can come up with their antioxidant systems to deal with that in an appropriate way.
And based on what I was talking about earlier, if they have, if you know of mold exposure, mold toxicity, that's coming out. The documentation is coming out very nicely on that blocks your innate response to oxidative stress, the NRF2. And so if you know there's mold, go even lower, go down to a little dose and start bringing them up. But we've had success with the diindolyl methane for reversing that blockage.
How do you know what, could you please repeat how you find what VO2 levels you're looking for? Like the optimum? Okay,
so how do you know what you know, you're measuring VO2s, how do you know if you got enough or too much or whatever? That was established. By the way, they measured VO2s back in the 20s and 30s. And the way I won't go into detail with the way they measured it, but it was very, you can imagine, extremely bulky, and nobody could ever actually do it unless they were in a hospital or a clinical situation like that. But we have data that goes all the way back then. There's one person that stands out from that era, and his name is Lusk, L-U-S-K. He studied and published lots of information on this and came up with a number of formulas for how to interpret VO2s. So you could predict what the VO2 ought to be, given your weight, given your height, given your age, given your sex. You plug all that stuff into the formula, and then your VO2 should be in that zone. So that's what we use. We use the Lusk formulas.
It would appear there's no more questions, so we should give a big round of applause to our speakers.
Dr. Schallenberger, I just wondered if you had any updates on your Lyme lecture from last year. Any new information with treating Lyme in your office?
Anything new since your last lecture on treating Lyme?
Oh, the Lyme thing. Boy, that would be the last question, because now I have to take 2 hours to answer you. Listen, if you want to know what the latest is on Lyme, and I'm telling you, it's just awesome. But if you want to know, yes, and there's a lot of stuff since I talked to you guys last. But there is a webinar I did a couple of months ago that just nailed it. The whole thing. It's a 2-hour webinar. If you were to send me an email, I'll send you the link to the webinar, because and you can access it. But just briefly put, this is what Lyme has taught me. Number one, multiple systems are down. The nervous system particularly is down. As Dr. Kidd was talking, basically all diseases start from the nervous system. That's where Lyme hits. The toxins from Lyme hit the nervous system. Nervous system is completely down. You can use antibiotics all you want. You don't deal with that, you get nowhere. Period. So there's multiple systems down. There could be 5, 6 systems down. Liver could be down. Autonomic nervous system is down. Mold all over the place. Interference fields, foci, You can have co-infections all over the place. You can have upregulated immune systems. You can have downregulated immune systems. You can have heavy metal toxicity. You can have emotional stress. You can have lack of sleep, pain. You can have pain, which absolutely throws everything out of whack. So multiple systems are down, okay? So with these patients, here's the deal. Number one, you have to have the capability of diagnosing every single system that's down. You can't just diagnose 3. If 5 are down and you diagnose 4, you're not going to get anywhere. So you have to have a diagnostic capability in your clinic to diagnose all the systems that are down. Unfortunately, not a lot of us have that. So you're at a deficit if you don't have all that available to you. Secondly, you have to have the ability to treat all the systems that are down. You got 5 systems down, you treat 4, patient doesn't get better. They'll feel better, but they won't get well. Thirdly, you have to treat all the systems that are down simultaneously. You can't do it sequentially. I can't like do my thing and then after I'm done, send him over to the biological dentist and he does his thing. And after that's done, send him over to the neural therapist and he does his thing. And after that's done, send him over to the allergy doc and he does his descent. That's not going to work. They won't get well. You have to treat them all simultaneously. Now here's the deal. That sounds difficult, and it is. And you got to guess it's fairly complex. It's simple in construct, but to organize that makes my staff a little bit crazy because I'm going to give them a treatment protocol that's very extremely detailed on this is what you do each time during the day. But if you do that, you will take seriously sick people and they'll be seriously well in 3 weeks. It's absolutely astounding what you can do if you have that kind of approach. So that I detailed that in that webinar I was talking to you about and how you can go about doing that.
Thank you.
Thank you.
Thank you, everybody. I'd like to thank the speakers for staying extra long.